the Skeptic's Guide to Emergency Medicine. Meet 'em, greet 'em, treat 'em, and street 'em. Today's date is September 10th, 2019, and I am your skeptical host, Ken Milne. The title of today's podcast is Old Men Take a Look at the Canadian CT Head Rules. I'm a lot like you were. And our guest skeptics, with an S, because we have two, is Dr. Sarah Berg. She is a PGY3 resident in emergency medicine at Washington University School of Medicine in St. Louis. She's interested in social determinants of health and in emergency department and health policy. Welcome to the SGEM, Sarah.
Thanks, happy to be here.
Ian, you've got a lot to live up to. So we also have Dr. Ian Hoser. Is that what it says? Hoser?
Oh, yeah.
Oh, no, sorry, I mispronounced that. He is from Canada, but it's Holly, not Hoser. Tough crowd. Okay. He is also a PGY3 resident in emergency medicine at Washington University School of Medicine in St. Louis. He's interested in ultrasound and international emergency medicine. Welcome to the SGEM, Ian.
Thanks for having me. Great to be here.
Now, I love how they say, oh, it's so fabulous to be here, bead of sweat. Now, the two of you, I was told, volunteered to be on the program. Tell me honestly, it's just us here. Did Jason Wagner, did he voluntold you?
I'd say enthusiastically voluntold.
Okay, all right. Well, we are doing this live, as you can tell, and we've got a mic for the audience. We are doing this live at WashU Grand Rounds, and I said it in my original presentation. This is one of the best, but I was corrected, the best, according to Jason Wagner, EM residency program in the country, apparently. Wow. Okay. Probably because of the program director.
I'm sorry. Don't worry. I apologize.
I've been updated again. Now, people usually have some banter at the beginning of their podcast. They talk about the weather, and it's really, I hate it. So what I want to do is ask you guys a question, and that is, what is the most irrelevant thing about you? Not the most relevant, the most irrelevant thing about you that your classmates don't know. Sarah, we're starting with you.
Cool. Let's see. Well, my classmates know this well, but maybe the listening audience doesn't know this. I am a diehard Chicago Cubs fan living in the heart of it gets sketchy.
Yeah, PGY3, one more year. Okay.
Well, Ken, I love breakfast, and I think pretty great blueberry pancakes, but some may say it just may be the maple syrup that I'm pouring on top of it.
You can't go wrong with maple syrup. All right. Let's get to a case, and who's going to give the case presentation?
I will do that. So here's our case. It's a busy night in the emergency department. Your next patient is a well-appearing 70-year-old man presenting after a mechanical fall from standing with loss of consciousness. He is neurologically intact with a Glasgow Coma scale of 15 1 hour after the fall, and there are no other external signs of trauma on your exam. He is not on anticoagulation and has no history of seizures.
I find that hard to believe that there's somebody out there that is not anticoagulated and falling. Does anybody else have a trouble with that sort of... Okay, it's not just me. All right, so head trauma is exceedingly common presentation in the emergency department with 2.5, I've got to teach you how to do this, million ED visits in the U.S., and that's a statistic from 2014. With the most significant proportion of visits occurring in the elderly, and we'll define that as 75 years of age or greater.
Right, so head trauma can result in a spectrum of brain injuries varying from mild to severe. In cases of severe injury, the decision to obtain head CT imaging is straightforward. In mild traumatic brain injury, or mild TBI, this decision can be more difficult as there may be no or minimal evidence of injury on exam. Traditionally, CT imaging was obtained for fear of missing intracranial pathology.
Yeah, and in an attempt to improve resource utilization, ED length of stay, limit costs, and improve outcomes, there have been multiple clinical decision rules created to help guide clinicians in their decision-making process. Two of the most commonly used rules include the Canadian CT Head Rule and the New Orleans criteria. Others include Nexus 2, the Neurotraumatology Committee of the World Federation of Neurosurgical Societies, the National Institute of Clinical Excellence Guidelines, and the Scandinavian Neurotrauma Committee Guidelines.
So I'm just going to ask your classmates, is Ian always this exciting? Now, we have covered the Canadian CT head rules multiple times on the SGEM. Once we did it with the EM Swami and Dr. Emily Junk back in SGEM number 106. It was a classic EM paper. You guys should know about it. Published in The Lancet back in 2001, done by the legend of emergency medicine, Dr. Ian Steele. We also discussed 3 other studies that compared the Canadian CT head rule to the New Orleans criteria. The bottom line from that podcast was that while both rules are highly sensitive, that means true positives, right, for findings, and for clinically important brain injuries, the Canadian CT head rule had higher specificity, so true negatives, and maybe more clinically applicable given its design to predict clinically important brain injuries.
So let's describe the Canadian CT head rule. It is a clinical decision instrument to help you decide if a patient with a mild head injury requires a head CT. Minor head injury in the study was defined as blunt head trauma resulting in amnesia, loss of consciousness, or an altered mental state defined as confusion or disorientation with a GCF score of greater than 13. And the Canadian CT head rule only applies to those patients with minor head injury and is not applicable to non-traumatic cases, GCS less than 13, age less than 16 years, people on anticoagulation like Coumadin, bleeding disorders, or obvious open skull fractures.
So Ian, we're going to help you out here. Have a swig. There we go. You're going to take us through the Canadian CT head rule. Come on, buddy. You can do it. You can do it. Sell it, baby.
So the Canadian CT head rule...
Oh, it would have been funnier if you got the Canadian CT
includes both high and moderate risk criteria. If any of these criteria are positive, a CT head is indicated.
Ooh, what are the 5 criteria? Because that's my favorite number, 5.
I bet. Let me tell you.
Okay.
GCS score less than 15 at 2 hours post-injury. Suspected open or depressed skull fracture. Any sign of basal skull fracture. Vomiting 2 or more episodes. Or age 65 years or older.
Okay.
That's you can.
Yeah, no. Jason will have a talk after. And there's a couple of medium risk factors.
Correct, there are, yeah. So the first one being amnesia before impact of at least 30 minutes, or dangerous mechanism. This includes pedestrians struck by a vehicle, being ejected from a vehicle, or having a fall from at least 3 feet or 5 stairs.
Now, the Canadian CT head rule is the most researched clinical decision rule in traumatic brain injuries and has shown sensitivities and specificities which are really good. The use of this CDR, such as the Canadian CT head rule, have the ability to reduce the amount of unnecessary head CT imaging obtained in the emergency department.
Unfortunately, the Canadian CT head rule uses age greater than 65 as a high-risk criterion for obtaining head CT imaging in minor TBI. So this is based on the initial validation study, which demonstrated an odds ratio of 4.1 for risk of clinically important brain injury. Clinically important brain injury is defined per the Canadian CT head rule as any acute brain finding revealed on CT and which would normally require admission to a hospital and neurological follow-up.
Yeah, so given this aging population, with an expected 60% increase in those greater than 65 from 2015 to 2050, and the already rapidly rising rate of ED visits for traumatic brain injury in this population, which has already demonstrated a 120% increase from 2007 to 2013, it's important for us to look forward in finding decision aids or pathways that may further help us, clinicians, risk stratify patients in this already higher risk cohort.
So that's the background information. Now we'd like to have a question that's really focused on what we're trying to answer in today's podcast. So Sarah, what is that clinical question we're trying to answer?
Right, our question is, what is the diagnostic accuracy of the Canadian CT head rule in patients 65 years of age or older in predicting clinically important brain injuries?
And Ian, what reference do we have?
Yeah, so we're looking at Fournier et al. Adapting the Canadian CT Head Rule Age Criteria for Mild Traumatic Brain Injury, Emergency Medicine Journal, 2019.
And I just want to point out a FOMED friend who was the senior author on that. That's Dr. Marcel Aymon from Quebec. He was the senior author on this paper, a faculty member of the Best Evidence in Emergency Medicine, and has translated a number of the SGEMs into French. All right, we're going to run through the PICO. That's the Population Intervention Control and Outcome. So who's doing the PICO with me?
I'll do the PICO.
Okay, what was the population?
The population was adult patients 65 years of age or older with confirmed mild TBI within the last 24 hours who received a head CT in the emergency department.
And I'll put the definition that they used for mild TBI in the show notes, plus the exclusion criteria. What was the intervention?
Application of a modified Canadian CT head rule with cutoff ages of 65, 70, 75, 80, and 85 years old.
What they compared to?
They did not have a comparison.
All right, let's go through the outcomes. How about the primary outcome?
Diagnostic accuracy of the modified Canadian CT head rule for clinically important brain injuries.
And secondary outcomes?
Reduction in CT scan usage.
All right, so that's the PICO. The author's conclusions were, quote, adjusting the age criteria for the Canadian CT head rule to 75 years old could be safe while reducing radiation and ED resources. A future prospective study is suggested to confirm the proposed modification. Right now we probe the literature for its validity using a standardized form or checklist to go through and ask key questions that could bias the information. So we're going to go through those quality checklists. Ian, you've got the checklist?
I do indeed.
All right, 9 questions. Here we go. First question, are these emergency department patients?
Yeah, this was a retrospective review of ED patients with mild traumatic brain injury, less than 24 hours from injury, who had CT imaging in the emergency department.
And the patients they captured, did they represent those with the problem?
Yeah, they seem to be. Although we don't have baseline characteristics for these patients, they did sample all patients greater than 65 years old who presented to the emergency department for possible brain injury.
And do you think all important predictor variables and outcomes were explicitly specified in the manuscript?
Yeah, so we're unsure on this one. Although the predictor variables are defined and set out by the Canadian CT head rule, interpretation of these variables from a non-standardized medical record could result in misclassification and some non-response bias. They did, however, have clear set outcomes for their primary and secondary outcomes, being clinically important brain injury, as well as reduction in head CT usage. Of note, when the initial head CT was ambiguous, they did have a blinded neuroradiologist read those scans. Exactly.
All right. The fourth question. This is a prospective multi-center study, including a broad spectrum of patients and clinicians, i.e. a level 2 study.
No, this was a retrospective cohort study at a single center.
All right, the fifth question, clinicians interpreted individual predictor variables and scored the clinical decision rule reliably and accurately.
Again, so here we're unsure. So there were 5 trained research assistants that interpreted the medical record. They also used an independent research assistant who reviewed 5% of those charts to look at inter-rater agreement. Looking at the clinicians who were involved in the initial patient care, 409 patients who had mild traumatic brain injury. Of those, 13 did not get a CT scan, meaning that clinicians in this patient population may not be following the Canadian CT head rule. As a result, we may have a sampling bias in that those who are sicker appearing in the emergency department are getting CT imaging.
Well, that's important because, you know, it's called a Canadian CT head rule, and Ian Steele and I have a little bit of a disagreement about should we be calling these rules, because they're clinical decision instruments. They're tools. They're supposed to guide our care. It doesn't mean every single patient fits in that box. And so, yeah, there were 13 patients that didn't get a CT scan. But we need to take that into consideration when we're evaluating their outcome on how this performed in its predictability. All right, number 6. Is this an impact analysis of a previously validated level 1 clinical decision instrument?
No, it's not.
That was pretty short.
It was.
Okay. All right. The follow-up, was it sufficiently long enough and complete enough? So did we follow these patients for enough time and completely enough? Did we capture them?
Yeah, no, so this was a retrospective study, so no follow-up period was included. However, the data collection did occur from 2010 to 2014, with the manuscript being released this year. So that could have provided an opportunity for follow-up to see if any of those patients who were initially seen without injury represented with a clinically important brain injury.
And this study was done in Quebec, and the reason I'm pointing that out for follow-up is in Canada we have something called a healthcare system. And it means that we capture almost everyone, unless they leave the country. They would present and be captured because it's all one healthcare system. And so that would be something that Marcel could have done, right, to look at follow-up. All right, the ninth and final question. Was the effect size large enough and precise enough to be clinically significant?
Yeah, so we're going to finish this off with another unsure here. So the authors based their power calculation on an expected frequency of clinically important brain injury of 25%. They based this on clinical experience. And it's actually similar to the original Canadian CT head derivation cohort of patients greater than 65 who they saw as 30% incidence of clinically important brain injury. They powered their study based on 99% sensitivity and 30% specificity and calculated that they would need 109 patients to observe 30 clinically important brain injuries. Ultimately, they included 104 patients in their final study analysis. Looking at the results, although the authors report sensitivity of 100%, the accompanying confidence intervals are wide, ranging from 89.1 to 100% for ages up to 75 years old. This demonstrates some imprecision in the measurement.
Were you sneaking in some results there?
I was, yeah.
Can we just move on to the results section now?
Taste test.
Are you sure? A little taste?
That's pretty good.
Good,
Yeah.
you know,
No pancakes.
No,
though.
no pancakes. Okay. So let's go through the key results. This retrospective chart review from a level 1 trauma center in a French-Canadian population identified just over 100 patients. So they got 104 patients included with mild traumatic brain injuries that met their inclusion criteria. The mean age of the cohort, so you know what age... Oh, that's not maple syrup.
That's just water.
Oh, sure. The mean age of the cohort was 77 years of age, and 58% were male. What were the key results?
Overall, they identified 32 clinically important brain injuries, or 30.7%, with 95% confidence intervals of 22 to 41.
I think we can skip the confidence intervals. We might lose some people in us, okay?
Less exciting. Okay, sounds good. So 8 of those 32 clinically important brain injury patients had no positive Canadian CT head criteria apart from age. And they found that a GCS score of less than 15 2 hours post-injury had the largest association with clinically important brain injury. And dangerous mechanism was least predictive. They calculated that the modified Canadian CT head rule would decrease 10% of CT images obtained in patients greater than 65 years old.
Wow, there are the key results. I've been sort of slow on the clicker there. Sorry, I've been so focused on the podcast. We'll put a table in to the show notes that show the sensitivity and the specificity of the various age groups, but just to pull out some key facts there. One of them was that if you had a GCS less than 15 at 2 hours, that was the most predictable of having a traumatic brain injury. And the mechanism of injury was the least predictive. And if you applied this, retrospectively, of course, so this isn't prospective, if you had applied this, you would have decreased imaging by 10% at age 75. But it's now my favorite time. It's time to talk nerdy. All right, and how many points do we have, Ian? What do you want to guess? Do you want to guess how many points? Huh?
A lot.
A lot. No, 5, my favorite number. I can count to it on one hand. Okay, so we're going to go through 5 nerdy points. The first one is about chart reviews in general. This is a single center retrospective chart review with unclear methodological quality. Retrospective chart reviews are frequently used for data extraction and can be biased. And Gilbert et al., way back in 1995, published a chart review paper to help improve the quality of the studies, of the chart reviews that were being done in emergency medicine.
And then Worcester et al. Expanded the original list of 8 to 12 quality indicators. This study that we're talking about incorporates 7 of the proposed 12 criteria for a high-quality chart review. We'll go through them.
Okay, so one of the issues is, did they train the abstractors before they collected the data?
Yeah, they said they had 5 trained research assistants.
And were the inclusion and exclusion criteria for case selections defined? And this can be a yes/no.
Yeah, they did, yes.
And did the abstractors use data from the abstract forms?
Yes.
And were inter-observer reliability mentioned? Did they mention it, yes or no?
Yes, they did.
And was the medical record database identified or described?
Yes, they did describe database.
And was the method of sampling described?
Yes,
And did they obtain ethics approval?
they did.
Okay, all right. So this study did not use the remaining variables described by Gilbert et al. And Worcester et al. Blinding, which may bias interpretation of chart documentation to favor outcome. Monitoring performance of research assistants to improve accuracy. Interrelated reliability testing, where they do a kappa value to say how much do they agree. Management plan of missing or conflicting data, and definitions of certain variables.
Although variables were inherently defined in the Canadian CT head rule, and chart reviewers were documenting presence or absence of these on a standardized form, the absence of a particular variable in the chart does not necessarily indicate true absence of this variable clinically. The authors stated that when a criterion was not accurately reported in the medical record, it was considered absent. However, the absence of evidence is not the evidence of absence, and taking this approach can result in a non-response bias, which could alter the validity of the results.
Okay, so that was the first point about chart reviews. Now we're going to talk about excluded patients.
Yeah, so as previously mentioned, there were 13 patients with mild traumatic brain injury who were excluded from the study as they did not receive head CT imaging in the emergency department. From this, it can be inferred that the clinicians from this patient population are basing their decisions to obtain CT imaging without the use of the clinical decision rule. As a result, if one's not using the rule, it's unlikely that all those components of that rule be documented, again, worsening the non-response bias. Secondly, with some clinicians not following the rule also raises concern for a selection bias towards sicker patients, in that those providers not using the Canadian CT head rule would be more likely to obtain imaging in those patients who appeared sicker clinically.
All right, the third point we wanted to talk about was wide confidence intervals. So they report 95% confidence intervals. And while the sensitivity for the age of 75 was 100%, you're like, wow, if I got 100%, Jason would be really happy with me. 100%? But then you look at that 95% confidence interval, and the lower end of that goes down to 89.1%. This means that using this age-adjusted Canadian CT head rule potentially could miss more than 10% of clinically important brain injuries. Is that acceptable? And that's a question I have for the audience. Is it okay to miss 10%? It will depend on where you work and patient expectations. Now, if you did a larger study, you could improve on that precision. The point estimate might be the same, but the confidence intervals would be narrower potentially, and so that would give you more confidence in these results. But I'm not sure I'm okay with a 10% miss rate, potentially. But we're going to talk about 10% more, because point number 4 is about a 10% reduction.
And there was an estimated reduction of CT utilization by raising the age from 65 years to 75 years, and they estimated that there would be a 10% reduction in CTs. This could possibly lead to less costs, less radiation exposure, and decreased ED length of stay. However, this does go back to point number 3, that 10% reduction in CTs. Is it worth the potential risk of missing up to 10% of clinically important brain injury? And the answer is probably different, like you alluded to, depending on many things, including your medical legal environment. While it may be more acceptable in Canada to reduce the utilization of the potential increase in miss rate, the zero miss culture here in the U.S. might find this trade-off unacceptable.
So just polling the audience, and what I want to do is do one clap. Okay, so if you agree with what I say, clap once. Ready? We'll just test this on a count of 3. 1, 2, 3, everybody. Okay, so that's the polling method. All right, do you think it's acceptable to miss 10% of patients? Do you think it's acceptable to miss potentially 10% of patients to reduce CT scanning in the elderly by 10%? Exactly. All right. Point number 5, prospective validation study.
Yeah, so we think this needs a prospective, multi-center validation study prior to clinical use. There have been numerous clinical decision rules that have been thought to be effective on derivation studies, but go on to fail external validation. For example, take the San Francisco syncope rule. The derivation study showed a sensitivity of 96% and a specificity of 62%. However, unfortunately, the subsequent validation studies demonstrated sensitivities and specificities of 74 to 87% and 52 to 57% respectively. Furthermore, very few clinical decision rules go the additional step and do an impact analysis. We do look forward to seeing this hypothesis of raising the Canadian CT head rule age cutoff to 75 years further explored in validation studies.
That's enough nerdiness. Now we're going to move on to comment on the author's conclusions, what they said, and compare them to what we think, the SGEM's conclusions. Sarah?
All right, so although we hope to one day see a modified Canadian CT head rule or some of their head CT decision pathway for our aging populations, we do not feel that this study is able to provide clinical guidance in management of minor TBI in the emergency department to reduce the age. However, it is relevant for hypothesis generation and for further prospective studies, and those further studies are required prior to clinical incorporation.
So for the SGEM bottom line here, we have this paper opens the door to further research to try to narrow the criteria for the Canadian CT head rule to further reduce unnecessary head CT imaging in the emergency department. However, further high-quality prospective studies are required prior to clinical application. Right, I can't remember who gave the case, but can you resolve the case?
Yeah, so given the current evidence and prevalence of clinically important brain injury in the patient population 65 years or older, you obtain head CT imaging. The CT scan is negative for acute pathology. Both you and the patient are happy. You provide the patient with return precautions and discharge him home.
And how are you going to take this information, Sarah, and apply it clinically?
The original Canadian head CT rule that was published back in 2001 has successfully reduced the number of head CT imaging obtained in the emergency department for minor TBI. One major limitation to the decision instrument is using that 65 years of age or older cutoff as a high-risk criterion. While this new study attempted to increase the age cutoff to 75 years is interesting and hypothesis generating, it is not yet ready for clinical application at this time.
And one of the nice things we do in the SGEM is that we try to take this really sort of nerdy approach and then digest it down and distill it and then bring it to the patient's bedside and say, how are we going to talk to the patient at the bedside about this information? And so Ian's going to do that. I don't know how he switched off the Canadian accent, because I can see him going up to the bedside and go, hey, how's it going, eh? Looks like you fell and hit your head, eh?
Moved on for too long.
No Timmy's for you. So Ian, in your best American accent, can you tell us what you would say at the patient's bedside, but as an American?
Well, firstly, Americans don't have accents.
Oh, okay.
There is some new evidence suggesting that we do not need to CT all patients older than 65 who have minor traumatic brain injury. However, best practice evidence at this time still indicates that CT imaging should be performed in this patient population given the increased prevalence of clinically important brain injury.
Now there's a sound effect that takes place in the podcast, and we announce the Keener contest. And because I'm in the U.S., I should explain what a Keener is. You refer to them as gunners. All right, so in Canada, we're just unarmed Americans with universal access to health care. So we don't call them gunners, we call them Keeners. And it's that individual that sits at the front, answers all the questions, goes up to Jason afterwards and goes, wow. Anyways, that's what a Keener is, so I just wanted to translate that. So the Keener contest winner last week was Ali Abdel Razak from the United Kingdom. They knew epilepsy came from the Greek word epilepsia, which means to take hold or take possession or seize. We had to come up with a gunner question, and so I said, why don't we do some St. Louis trivia? Now, I understand if you know the answer, don't shout it out, because we're recording this, because the first person that sends me via social media the correct answer will receive a Cool Skeptical Prize. And it exists. But you have to play to win, and you have to win to find out what the Cool Skeptical Prize is. All right, so what's the question?
All right, so this is WashU trivia. How many Nobel laureates have done research at Washington University in St. Louis, including 5 who received the Nobel Prize for research that they conducted here?
You see, I couldn't just make it into an easily Googleable or whatever. You can't just Google it or just ask Surrey. So we had to have a little bit of, effort into this. So how many Nobel Prize winners came from St. Louis? 5 of which were here at St. Louis, at WashU, at the time when they received their Nobel Prize. So hint, it's more than 5. So if you guess 4, Jason, again, we're going to have a conversation. All right, so if you know the answer, send it to me at the sgem@gmail.com with Keener in the subject line. The first correct answer will receive a cool skeptical prize. There is some other FOAMed resources on the Canadian CT head rule, and I will list them in the show notes. But I want to thank Sarah for coming on the show and doing this live in front of your contemporaries. So thank you very much.
Thanks for having me.
And thank Ian. He'll drown his sorrows in maple syrup.
Whiskey flavored.
Oh yes, we had maple whiskey flavored maple syrup last night. Thanks, Chris. So now what I wanted to do is a little bit of audience participation. This is the final part. We get to read the tagline. You're in Missouri, so I'm hoping that you can read the tagline for the SGEM in your best Missouri accent. So you did a great job of the 1, 2, 3 clap thing. So we're going to do the 1, 2, 3, and then you're going to read the SGEM tagline in your best Missouri accent. You ready? Just think of you're from the Ozarks. Okay? You ready? 1, 2, 3. Remember to be skeptical of anything you learn, even if you heard of a skeptic's guide to emergency medicine. Talk to everyone next week.